Osteosarcoma, as the name would imply, is osseous matrix. And we're going to go through a bunch of pictures here. They're generally in the metaphysis, tender firm mass, and they can be in any bone. They're typically around the knee, a lot of growth at the knee. That's why we see them in teenagers, the distal femur, proximal tibia. But they can also be in the proximal humerus. So here's a good picture. Shows bone, right? Looks like bone. It's osseous matrix. That, by definition, is an osteosarcoma unless proven otherwise. Here's another one, maybe a little more subtle, and sometimes you see some that are way more subtle than this. Anytime we see this little, it may not be projecting super great, but you see some ossification here in the soft tissues. There's clearly a soft tissue mass here. Sometimes all you see is some little wispy lines of bone forming. And that's the soft tissue mass being very aggressive coming out of the bone. The more aggressive something is, it's pretty subtle. It's blowing through the bone and not making a lot of reaction. And the body's trying to keep up, making these little fragments of bony tissue. And so sometimes all you see is that onion skinning and periosteal reaction, and that's a very aggressive sign. So whenever you see something like that, always get an MRI to get a better picture. So here's some examples of reconstructions, and we're going to go through a bunch. This one is called an allograft prosthetic composite. You can kind of see that here, because see that line right there? That's the osteotomy site. That's where we took the tumor out. So all of that is a bulk allograft that's plated to the tibia, and then a very long stem going through it to give it some support past that osteotomy site. Hinge knee replacement, rotating hinge, and this is somebody that required a wide resection. I think it was that picture before of that proximal tibia for an osteosarcoma. And the advantage of using these allograft composites, other than all metal, which I'm going to show some pictures soon, is that you can attach to the allograft through the patellar tendon. So that attachment's there. In theory, you're attaching a tendon to tendon. You might get some better function. And these kids actually do get decent function. Some people argue that attaching them to the metal megaprostheses through the actual drill holes that come in the prosthesis can actually have pretty good function as well. So there's a little bit of debate about that, because you can imagine these bulk allografts with this big chunk of dead bone. Infection rates are pretty high, and we have to do flaps. We usually cover these with a gastroc flap because it's a big, bulky bone, and we need good soft tissue coverage, and that gastroc flap helps with the extensor mechanism too.